Maternal and child health care in community health settings. Introduction. Mothers and children constitute more than half of the population, 62%. They are regarded as the most vulnerable members of society because they face special risks, for example, pregnancy and delivery among women, and susceptibility to communicable diseases, and developmental and survival challenges among children. So both groups are in need of special attention. Emphasis is placed on the promotion of health and the prevention of death, disease, and birth defects. Objectives of the Maternal Child Health Centers program. Ensure that every expectant and nursing mother maintains good health, has a normal delivery, bears healthy children, and learns the art of child care. Conduct activities for the health promotion of children from 0 to 6 years of age. Functions of MCH centers: premarital care and counseling, maternity care, infant and preschool child care, health checkups, vaccinations, and etc. Family planning, health education, and social care. Importance of premarital care: early detection of health problems and accordingly better chance of treatment, providing guidance, preparation for marriage, family education, training in the art of child rearing and family planning. Prevention of health problems for the couple and their future children. Components of premarital care: premarital examination, including history taking, physical examination, and laboratory examinations. Premarital education, premarital counseling. Premarital examination, history taking, personal history, name, age, occupation, education, address, and religion. Menstrual history, menarche, dysmenorrhea, menstrual disturbances. Medical history, cardiovascular diseases, renal diseases, infectious diseases, hypertension, tumors, surgical procedures or trauma, venereal diseases, DM, and TB. Family history, genetic diseases, hypertension, DM, heart diseases, and psychic disorders. Kin relationship with spouse. Premarital examination, physical examination. Complete physical examination including heart examination, chest examination to detect any disease, pelvic measurements to detect contracted or deformed pelvis. Premarital examination, laboratory investigations. Investigations include cytogenetic studies, complete blood counts that include white and red blood counts, hematocrit and hemoglobin, and platelet counts. Serological tests to detect any infectious disease of bacterial, viral, or parasitic origins. Premarital examination, laboratory investigations continued. Bacterial infections such as for the Wesermann reaction to exclude syphilis and streptococcal antibody tests for rheumatic fever and glomerulonephritis. Viral tests such as rubella antibody tests and hepatitis tests. Antibody test to detect human immunodeficiency virus. Parasitic tests, TMP antibody test for toxoplasmosis. Urine analysis for sugar and albumin to exclude TM or kidney diseases. Premarital examination, laboratory investigations continued. Analysis of the man's seminal fluid to determine its speed, morphology, volume, and number of sperms for early detection and intervention in case of infertility. Premarital education. The following areas of health education should be emphasized: parents' health, nutrition, safe environment, role of the father, role of the mother, child rearing, sex education, and family planning. Premarital counseling. Gather counseling model. The gather counseling model can be used in premarital counseling. It includes 6 elements. Greeting the couples, introduce yourself, learn their names, ensure a calm and proper atmosphere, and inform them that the conversation is confidential. Asking about them, collect relevant information including personal family, medical, surgical, and obstetrical history. Assess their needs, tell them relevant information they may need, help them to make decisions regarding their future lives, explain about their choices. This includes correcting any misunderstandings and myths, providing information about their own sexual health, preparing for parenthood, and discussing the formation of their expected family. Return for follow-up visit. Antenatal care. Goals of antenatal care. The main goal is the safety and welfare of the mother and her fetus, the preparation of mother for labor, lactation, and subsequent care for her child, the early detection and appropriate treatment of high-risk conditions, the reduction of maternal and infant mortality, stillbirth, and prematurity, to increase the number of breastfed babies. Schedule of antenatal visits. 12 to 15 visits in normal cases. First trimester 1 visit, total is 1. Second trimester 1 visit a month, total is 3. 7th and 8th months 2 visits each month, total is 4. 9th month 1 visit each week, total is 4. Focused antenatal care, the 4-visit A&C model outlined in WHO clinical guidelines. First visit from 8 to 12 weeks, second visit from 24 to 26 weeks, third visit is 32 weeks, fourth visit from 36 to 38 weeks. Initial visit, history taking, general examination, local examination, laboratory investigations, dental examinations. Rhesus factor. All the Rh-negative pregnant women should receive Rh immune globulin at 28 to 30 weeks gestation, and again after delivery of an Rh-positive infant. If the Rh-negative woman delivers an Rh-negative infant, no past-delivery treatment with Rh immune globulin is needed. Rh immune globulin should be administered intramuscularly in the gluteus maximus. If the Rh-negative woman has received or needed to receive immune globulin at any time during her pregnancy, this doesn't contraindicate her receiving Rh immune globulin at 28 to 30 weeks gestation. The Rh immune globulin is a specific treatment for the Rh-negative clients to prevent sensitization. Rh sensitization occurs when Rh-negative women forms antibodies following an exposure to Rh-positive red blood cells. Hemoglobin. If hemoglobin is below 12.6 grams per deciliter, 85%, iron, folic acid, and vitamins B and C are prescribed. If below 10.3 grams per deciliter, 70%, blood investigation is carried out. Return visit. At the 30th week, hemoglobin estimation, abdominal examination, size of the uterus. Tetanus immunization for pregnant women. Dose of tetanus. Number 1, it's given at first contact or as early as possible in pregnancy, and the expected duration of protection is none to 0. Number 2, at least 4 months after tetanus 1, from 1 to 3 years and 80%. Number 3, at least 6 months after tetanus 2 or during subsequent pregnancy, at least 5 years and 95%. 4, at least 1 year after tetanus 3 or during subsequent pregnancy, at least 10 years and 99% of protection. Number 5, at least 1 year after tetanus 4 or during subsequent pregnancy, for all childbearing age years and possibly longer, 99% of protection. Vaccine and its general recommendation for use in pregnant women. Hepatitis A, PA's decision on risk versus benefit. Hepatitis B, recommended in some circumstances. Human papillomavirus, not recommended. Influenza inactivated, recommended. Live attenuated influenza vaccine, contraindicated. Health education. After routine examination, every pregnant woman should receive health education according to her condition. Husbands should be included in the education sessions in order to understand their expected role and the changes occurring to their wives. First trimester, avoid taking any drugs without doctor order. Hot bath because may cause faint and tube bath. Contraindicated are X-ray, vaginal douching, catheter, enemas. Second trimester, avoid heavy weights, may predispose to abortion. Constant standing lead to varicose veins. Climb to reach high shelves because of overbalancing and her tendency to faint. Airlines after 32nd week as there is possibility of premature labor. Warning: without frightening, tells pregnant women about vaginal hemorrhage, stopped fetal movement, any abnormal secretion, abnormal vomiting, edema, headache, abdominal pain. Adequate nutrition. Calories 2,500 per day, protein 85 mg per day, calcium 1,500 mg per day, iron 27 to 30 mg per day. NB, daily iron requirement for adult women is 18 mg per day. Smoking. Smoking leads to spasm of placental blood vessels, which can lead to the following: fetal anoxia, low birth weight neonates, LPW, intrauterine growth retardation, IUGR, prematurity, premature rupture of membranes, PROM, and placental abruption. Natal care. Objectives of the natal care: to assist the mother to have normal delivery, provide emergency care if necessary, safety for both mother and fetus. The due date may be estimated by adding 280 days, 9 months and 7 days to the first day of the last menstrual period. This is the method used by pregnancy wheels. The accuracy of the EDD derived by this method depends on accurate recall by the mother, assumes regular 28-day cycles. Ovulation and conceptions occur on day 14 of the cycle. Naegele's rule is a standard way of calculating the due date for a pregnancy, adding 1 year, subtracting 3 months, and adding 7 days to the first day of a woman's last menstrual period. The result is approximately 280 days, 40 weeks, from the start of the last menstrual period. Advantages of home delivery. The mother feels happier in her own home with her family around her. The mother often doesn't want to be separated from her other children and husband. The family routine can easily be rearranged when the baby is part of the family from the beginning. The mother will receive advice concerning her needs in her own home. The expenses are minimal and risk of cross-infection is minimal. Disadvantages of home delivery. Normal cases may become suddenly complicated despite the best screening process. Certain complications are difficult to predict. There is no constant attention for the mother and baby, and skilled help is not readily available. The mother may resume her household responsibilities too soon when there is inadequate help in the home. The mother's diet may be neglected. Contraindications for home delivery. The home, overcrowding, infectious disease present, unsanitary conditions. The mother obstetrical. Cephalopelvic disproportion, preeclampsia and eclampsia, multiple pregnancy, antepartum hemorrhage, Rh isoimmunization, previous cesarean section, difficult forceps delivery, postpartum hemorrhage or adherent placenta, stillbirth, neonatal death, prima gravida over 30 years, multigravida plus 4 years, multigravida over 36 years. Medical, cardiac disease, tuberculosis, diabetes, essential hypertension, anemia. The baby, any abnormal presentation position, gestation period less than 36 weeks, Rh hemolytic disease through post-maturity. Postnatal care. It is the period of time from the end of the third stage of labor until the time at which the pelvic organs have returned to normal, about 6 weeks, 6 to 8 weeks. Goals of postpartum care: helping the psychological changes of this period to occur as spontaneously as possible, helping parents in adjusting to and accepting new rules, helping strengthen mother-child or parent-child bonding. Postpartum checks. First day vital signs, PP, general examination, level of the fundus, lochia, perineum, episiotomy. Third day flow of milk, slight increase of temperature, lochia, level of 1 fundus, perineum. Fifth day level of the fundus, lochia serosa. Seventh day level of the fundus, lochia serosa, cord for the baby. 10th day temperature, puerperal sepsis, level of the fundus, and lochia alba. 15th day involution of uterus, lochia alba. 21st day lochia alba, any complication or complaints. 40th day postpartum examination, family planning, BCG vaccination for the infant. Health education about avoiding puerperal infection, care for episiotomy, rest and sleep, diet, early ambulating, breast care, psychological changes, the bowels, exercises, family planning. Objectives of child health services: health promotion of child, prevention and control of diseases and hazards, prevention of disability and rehabilitation, reducing child mortality. Function of MCH centers for child care. First, preventive services, which include prenatal and natal care, newborn care, health promotion of infants and preschool children, prevention and control of communicable diseases, health education, maintenance of health through periodic medical examination. Second, curative services. Third, social services for mothers and children. Maintenance of health through periodic medical examination. Periodic examination of the child for check-up of the general condition and growth and development through regular visits to MCH at the following schedule: monthly for the first year, twice a year for the second year, every year till the age of 6 years. High-risk mothers, biological, socio-economic and demographic factors, medical factors, obstetrical factors, risk factors at the time of labor. Biological, socio-economic and demographic factors. Age less than 18 years or more than 35 years. Parity, first or fifth or more pregnancy. Birth spacing too short an interval, less than 2 years, and too long, more than 10 years. Education of mother, illiterate mothers are at risk. Illegitimacy, inadequate prenatal care, poverty, substandard housing and nutritional deprivation, X-ray exposure, irradiation, occupational hazards and pollution, drug abuse, migrant family status, alcoholism, smoking, history of mental illness. Medical factors: diabetes mellitus, heart disease, hypertension, renal disease, hypo or hyperthyroidism, malnutrition, anemia, hemoglobin 9 mg, tuberculosis, syphilis, and rubella. Obstetrical factors: history of stillbirth. Stillbirth is the death or loss of a baby before or during delivery. Both miscarriage and stillbirth describe pregnancy loss, but they differ according to when the loss occurs. In the United States, a miscarriage is usually defined as loss of a baby before the 20th week of pregnancy, and stillbirth is the loss of a baby after 20 weeks of pregnancy. Stillbirth is further classified as either early, late, or term. An early stillbirth is a fatal death occurring between 20 and 27 completed weeks of pregnancy. A late stillbirth occurs between 28 and 36 completed pregnancy weeks. A term stillbirth occurs between 37 or more completed pregnancy weeks. Obstetrical factors: repeated abortion, previous cesarean section, RH incompatibility, toxemia, multiple pregnancy, placenta previa. Placenta previa is a condition in which the placenta is implanted near the outlet of the uterus, so that at the time of delivery the placenta precedes the baby. Placenta previa can cause painless bleeding in the last trimester of pregnancy, and it may be a reason to perform a C-section. It's also known as low placenta, contracted pelvis, and history of difficult or prolonged labor. Risk factors at time of labor: rupture of uterus, premature separation of placenta, difficult or prolonged labor, uterine inertia, failure of the uterus to contract with normal strength, duration, and intervals during childbirth. It's also called uterine atony, premature labor, and abnormal presentation. High-risk children: factors related to mother health and factors related to newborn. Factors related to newborn: lack of newborn care, prematurity, death during first year of life 17 times than normal, low Apgar score, congenital malformation, birth injury, prolonged hospital stay, infection and poor progress, mental handicaps, early stoppage of breastfeeding, introduction of complementary food either too early or too late, frequent episodes of infection. Definition of maternal mortality. Maternal mortality is the death of a woman while pregnant or within 42 days of termination of pregnancy, irrespective of the duration or the site of pregnancy, from any cause related to or aggravated by pregnancy or its management. It doesn't include death from accidental or incidental causes. Incidental versus accidental. The accidental means unintentional or happening by chance. The incidental means secondary or non-essential. It often refers to something that occurs in connection with a more important activity or event. Maternal mortality ratio. Maternal mortality ratio equals number of maternal deaths in 12 months divided on number of live births in the same 12 months multiplied by 100,000. Live birth. Live birth refers to the complete expulsion or extraction from its mother of a product of conception, irrespective of the duration of pregnancy, which after such a separation breathes or shows any other evidence of life. For example, beating of the heart, pulsation of the umbilical cord, or definite movement of voluntary muscles, whether or not the umbilical cord has been cut or the placenta is attached. Each product of such a birth is considered live-born. Data sources: vital registration, health service records, household surveys, and census. Maternal mortality rate. Maternal mortality rate equals the number of maternal deaths in 12 months divided on average number of women of reproductive age in the same 12 months multiplied by 100,000. The main causes of maternal mortality: hemorrhage, hypertensive disorder of pregnancy, infection, genital sepsis, ruptured uterus, cesarean section, abortion, and obstructed labor. Definition of neonatal mortality. Neonatal mortality is the death of a live-born child who is less than 28 days old. Neonatal mortality. Neonatal mortality rate equals number of infant deaths during first 4 weeks of life in given area and year, divided on number of live births in the same area and year multiplied by 100,000. The main causes of neonatal mortality: prematurity. Premature babies are more susceptible to infection and asphyxia. Birth injury, congenital anomalies, infection either at birth, like neonatal tetanus and sepsis, or shortly after birth, pneumonia and diarrhea. 1/3 of neonates die due to birth asphyxia, tetanus and sepsis, or shortly after birth due to pneumonia and diarrhea. National programs related to child health. The following programs will be discussed: Integrated Management of Childhood Illness, IMCI, and School Health Program. Integrated Management of Childhood Illness and Health. Every year about 12 million children die before they reach their 5th birthday. 7 in 10 of these deaths are due to the 5 major killers of children: acute respiratory infections, mostly pneumonia, diarrhea, measles, malaria, and malnutrition. IMCI is an integrated strategy that takes into account the variety of factors that put children at serious risk. Rationale of IMCI. Most of sick children present with signs and symptoms related to more than one condition. More than one underlying cause contributes to the illness of the child. This overlap means that a single diagnosis may not be appropriate. Treatment needs to combine therapy for several conditions. So an integrated approach to manage sick children is more useful in order to go beyond single diseases and focus on the overall health of the child. Factors influencing the decrease of maternal mortality factors. Good coverage during the antenatal, natal, and postnatal period. Increase the use of hospitals and specialized health care centers for maternity clients. Establishment of high-risk centers for mother and infant care. Prevention and control of infection with antibiotics and improved techniques. The availability of blood and blood products for transfusion. Lowered rate anesthesia-related deaths. Family planning. In-service training programs for health personnel as well as traditional birth attendants. Supervision of midwives, assistant midwives, and nurses. raising the age of marriage more than 18 years, improving standard of living of mothers, application of research for prevention of maternal mortality. Measures to reduce neonatal mortality: raising the standard of community, better housing, education, better advanced medical care, good nutrition and income. Environmental sanitation, educate girls the art of mothercraft and neonatal care, good coverage during the antenatal, natal and postnatal period, improvement of MCH services, especially the educational activities, immunization, special care to premature neonatal, prevention of gastroenteritis and promote treatment of acute respiratory infections, family planning, encourage breastfeeding and proper weaning.